Hello. Okay. Welcome back, everyone. Thank you very much. We hope you had a chance to check out the poster session and community partner booths and are looking forward to an engaging lunch symposium with our very own Elena-Barbir. This session and lunch has been generously sponsored by our friends and partners at Alexion, which is the Rare Disease Division of AstraZeneca. We are joined today by Dr. Shauna Abel from the Alexion team, who has been instrumental in supporting our ATI Research Day for several years now. And we want to thank her and her team for their tremendous support of organ donation and transplantation research in Alberta. So I'm very proud to introduce my colleague, Dr. Elena-Barbir, who has just recently joined the Division of Nephrology at the University of Alberta after she completed her general nephrology training at the University of British Columbia. She went on to complete 2 additional fellowships in transplant nephrology and onconephrology at the Mayo Clinic in Minnesota. Dr. Barbir is working to establish an onconephrology clinic here at the U of A, in addition to her active kidney transplant clinical practice. Her clinical and research interests include recurrent disease in kidney transplant recipients, specifically complement-mediated thrombotic microangiopathy and monoclonal gammopathies of renal significance, immunotherapy-related renal complications, and drug-induced thrombotic microangiopathy in oncology patients. The title of her talk today is Treatment Strategies for Kidney Transplant Recipients with Thrombotic Microangiopathy. Welcome, Dr. Barbir.
Thank you for the introduction, Dr. Christie, and thank you to the organizers for having me. I'm a junior staff, so this is truly an honor to be here. I'm just going to figure out if I've got this. Okay, perfect. So I'm going to talk about treatment strategies for kidney transplant recipients with thrombotic microangiopathy today. I just wonder if there's a way that I can see my slides without looking at my slides. Yeah, I don't need notes. I just have to. Okay, that's okay. I'll manage. I'll just move this a little bit. There we go. Then I can see what the next one is. All right, so to start, I have no disclosures other than this symposium or this lecture was generously funded by Alexion. I also have a personal disclosure, which is that I am not a complementologist myself. I've just had recurrent exposure to different pathologies that have been mediated by complement. As an onconephrologist, I've had several patients with drug-induced thrombotic microangiopathy. I also followed several patients who had complement-mediated TMA, underwent kidney transplant with eculizumab prophylaxis and did well. And then as I was following these patients, one of the topical questions that came up over and over was whether or not discontinuing terminal complement blockade made sense once they were stable post-transplant. And so that sort of piqued my interest in complement. And I started working with Alexion back when I was at Mayo and made the transition here. So that's sort of where my interest comes. It's not from specific training in complement, as some others who are very active in this field have had. So the outline for today's presentation will be first discussing AHAS. There's 2 different terms that I'll be using: atypical hemolytic uremic syndrome, which I'll use more frequently because this is the common term that's used. But there is a push towards referring to it as complement-mediated thrombotic microangiopathy, though different parties will have different affections towards AHAS versus complement-mediated TMA, with the argument for complement-mediated TMA being that you need to have shown that there are genetic abnormalities associated with the thrombotic microangiopathy that patients are experiencing. And so for that reason, I'll just stick to AHAS to make it less confusing for the rest of the talk. I'll be talking about the diagnosis and the role of genetics just in the initial presentation. Then I'll talk about transplant-specific considerations in patients with primary AHAS. Then I'll talk about treatment approaches, the specifics for transplant patients, and then future directions in the field. So to start, an overview of thrombotic microangiopathies. It is a diverse set of syndromes that are united by common clinical and pathologic features. So in order for something to be a thrombotic microangiopathy, you need to have microangiopathic anemia as well as thrombocytopenia. And typically the biochemical changes that you see with this are low hemoglobin, low platelets, schistocytes on peripheral smear, elevated LDH, unconjugated hyperbilirubinemia, and low haptoglobin. And depending on which study you look at, they'll use that they'll typically use a subset of those biochemical changes to call thrombotic microangiopathy. For AHAS in particular, what I'm interested in is ischemic organ damage in the kidney. And so primary AHAS will affect multiple organs, but from my presentation, I'll just focus on the kidney. And so the typical pathologic changes you see are fibrin thrombi and glomerular capillary loops and arterioles. Sometimes you'll see fragmented red blood cells, endotheliosis, mesangialosis, arterial intimal edema. And then if the process has been subacute or chronic, then you may see some chronic changes, including arterial onion skinning, an MPGN pattern of injury, though IF negative in primary AHAS, and ischemic glomeruli. And so we know that thrombotic microangiopathy is a result of terminal complement pathway activation, and there's multiple ways that you can activate the terminal complement pathway via the classical pathway, the lectin pathway, or the alternative pathway. And for primary AHAS, we suspect that this is all driven by alternative complement pathway activation. As we know, the alternative complement pathway is constitutively active due to C3 takeover. And so overamplification is avoided due to several regulatory factors like complement factor H, complement factor I, and membrane cofactor protein, sometimes referred to as CD46. And amplification relies on activating factors like complement factor B and complement factor D, which then allow for the formation of C3 convertase, which then leads to C5 convertase, and then soluble membrane attack complex formation. What we also know is that renal histology is nonspecific. There are some differences between some of the TMA syndromes. For example, scleroderma renal crisis, we know typically will affect the arterioles and spare the glomerular capillaries, but we would never make the diagnosis based on histology alone. And so I just have here several slides showing the typical findings on renal histology of thrombotic microangiopathy in the acute phase. So you can see in slide A there, the AHAS microthrombi affecting the vascular pole. You can see onion skinning in that second slide there, which is more of a chronic change, but as well as some myxoid changes. And then glomerular microthrombi in that third picture, so C. And it's just the skinny arrows essentially are all showing glomerular microthrombi, and then the thicker arrows are showing the arteriolar changes, which is either thrombi or endotheliosis. In terms of an approach to the diagnosis of thrombotic microangiopathy, there's been a shift in how we think about this over time as we've understood the molecular basis of the disease with greater depth. So primary AHAS, as you can see from this diagram here, and there are different approaches. I just chose to pick this approach from Dr. Fakuri et al. Just because this makes the most sense to me based on my clinical practice. So initially, you want to make sure that you're not dealing with TTP as it is a life-threatening emergency. So that's why the first rule-out category there is descendant ATOM TS13, and then deciding on whether or not to initiate plasma exchange based on your pretest probability that it is TTP that the patient is presenting with. Then you would look for causes of secondary TMA, which include autoimmune diseases, drugs, infections. You'll notice specifically that malignant hypertension is not up there, and I'll speak about that more as the presentation goes on. Malignancy would be another cause. Then you would want to make sure that you rule out typical hemolytic uremic syndrome, so Shiga toxin associated, and you would send a Shiga toxin PCR for that. There's also cobalamin deficiency HUS, and so that would involve genetic testing and serum homocysteine testing. And finally, if you've ruled out these other things, and depending on the clinical presentation of the patient in front of you, you can reach primary AHAS. Of course, to the side there's pregnancy-associated AHAS as well, which has some overlap with primary AHAS as we're finding out. And then the hypertensive malignancy piece is interesting because the more we're learning, the more we're starting to question how many of the patients that we're calling hypertensive malignancy are truly atypical HUS that are presenting with a hypertension emergency. And it turns out that probably that number is around 50%. And so that's why it's sort of on the bottom there with a bidirectional arrow. Of those that have primary AHAS, about 50% will have a complement genetic abnormality. And those that don't have a complement genetic abnormality, we suspect that we just don't know what to look for yet. We haven't recognized it yet. A proportion of patients will have anti-complement factor H autoantibodies as well. And going back to the pregnancy piece, in a study done by, again, Dr. Fakuri, this was a retrospective study that she did, in 21 patients with pregnancy-associated TMA, 85% did have complement genetic abnormalities. So again, thinking that perhaps this is the second hit for their AHAS to present and not necessarily a separate category. So looking at the prevalence of genetic abnormalities in complement proteins for the different etiology of TMA, in the old classification, we thought of it just as primary and secondary. And so primary, there's TTP with sometimes genetic abnormalities, AHAS with about 50 to 60% prevalence of genetic abnormalities. And then within secondary, as I mentioned, hypertension will have a 50% prevalence, which is likely then that it is a primary AHAS complicated by hypertensive emergency. With drug-induced TMA and autoimmune diseases, there is typically not a complement genetic abnormality, so it truly is a secondary form. And then infections will have a variable prevalence of genetic abnormalities. And typically, the genetic abnormalities that we see will be due to a gain-of-function mutation in complement activating genes like C3 and complement factor D, and complement factor B as well. I did not list complement factor D there because it's not very common. Complement factor B is much more common, but that is a possibility as well. And then loss of function mutations in complement regulatory genes, such as complement factor I, H, MCP or CD46, and then complement factor H-related proteins. And we also know that genetic abnormalities in complement factor H-related proteins from 1 through 5, but 1 and 3 specifically, are associated with complement factor H autoantibodies. Other mutations will typically affect the coagulation pathway, and these will include thrombomodulin, DGK epsilon, plasminogen, and INF2, which is actually an actin-regulating gene, so slightly different. And interestingly, INF2 is strongly associated with FSGS. The other interesting piece is that despite this strong genetic association, penetrance of AHAS in families is only about 50%, and so that provides further corroboration for the two hits hypothesis. So you have a predisposition to developing AHAS, and you need a second hit, whether it be infection, pregnancy, surgery, or relevant to my practice, transplant. In this study by Timmermans et al., back in 2019, they looked at this association between malignant hypertension and genetic complement abnormalities with the suspicion that, like I previously mentioned, these are primary AHAS patients presenting with malignant hypertension. So what they did is they looked at patients with hypertensive emergencies, plus minus extrarenal disease, usually CNS involvement or retinal hemorrhage, who also had thrombotic microangiopathy demonstrated on kidney biopsy. They then took serum from these patients and looked at ex vivo C5b9 formation on the endothelium. And so this is essentially evidence of terminal complement pathway activation. And what they found is that in 18 patients out of the 26 that was included in the cohort, there was massive C5b9 deposition. And 9 of those 18 patients did have pathogenic variants in complement-associated genes. And so the variants they screened for were complement factor H, I, CD46, complement factor B, C3, the CFHR genes, thrombomodulin, and DGK epsilon, which is what is usually included in the panels that we send for AHAS workup. Their definition of hypertensive emergency was a blood pressure greater than 180 over 120. And I'll show you the mean blood pressures on the next slide. They also found that 8 patients did not have evidence of terminal complement pathway activation when they looked at the ex vivo C5b9 formation. And of those 8 patients, none of them had complement genetic abnormalities. And blood pressure control was effective in 5 of 8 of those patients versus not effective in 17 out of 18 of the patients with evidence of terminal complement pathway activation. Further arguing that potentially terminal complement blockade would have been beneficial for those patients in that first arm. They then looked at a subset of these patients who underwent kidney transplant and found that there was a risk of recurrence of 47%, risk of recurrent TMA after kidney transplantation. Looking at the mean blood pressures in the arm that had the evidence of terminal complement pathway activation, the mean blood pressure was 210 systolic over 120 diastolic, and in the shear stress-induced TMA arm, 236 over 146, showing that on average higher blood pressures were needed to achieve shear stress-induced thrombotic microangiopathy. Interestingly, 73% of patients did not have profound systemic hemolysis and had simply biopsy-proven renal TMA, indicating that we can miss the diagnosis if we don't have a high index of suspicion and proceed with a renal biopsy in these patients, though it can be challenging at times if they have hypertensive emergencies because you need to control their blood pressure well enough to be able to do the kidney biopsy safely. And looking at progression to end-stage kidney disease at 3 months, 72% progressed in the positive, 72% of the patients progressed in the complement-mediated TMA group, we'll call it that, and then about 30% in the shear stress-induced TMA arm. The only issue I have with this is we don't know whether or not those patients had underlying CKD. That was not part of the baseline criteria that was provided for the study. But either way, it is an impressive difference between the two arms, again, arguing for the use of terminal complement blockade in these patients. This led them to develop recommendations, which essentially state if there is evidence of terminal complement pathway activation for patients who come in with hypertensive emergencies, then they warrant terminal complement blockade as therapy. The one thing to be cautious of is, as I mentioned at the beginning of the presentation, we are starting to recognize that complement is involved in driving pathology in multiple different conditions, and terminal complement blockade may not always be the right answer. So we have to take the evidence with a little bit of skepticism to make sure that we're not over-prescribing this therapy. And so to this end, there was a KDIGO controversies conference in 2022 looking at complement and kidney disease more broadly. There had been one in 2015 that looked primarily at AHAS, and this sort of expanded the scope. And to recognize the role of complement in disease in general, they sort of graded it by complement dysfunction has a primary role versus complement dysfunction is a secondary driver of injury. And for this secondary group, the role of therapy is a little bit less clear at the present moment. And so primary driver of injury conditions would be AHAS, 3CG, and primary ICI-MPGN. So for the first part, the key takeaway points are renal TMA represents a histologic pattern of injury which is associated with a variety of TMA syndromes. Determining the etiology of the TMA is critical to determining appropriate therapeutic intervention, as well as in predicting the risk of recurrence in a kidney transplant recipient, which I'll speak to more. And as our diagnostic toolbox grows, functional complement testing, genetic testing, ex vivo solid phase C5b9 testing, which is not widely clinically available by any means, the role of complement in multiple TMA syndromes becomes apparent. So how do we risk stratify transplant patients? Both the KDIGO 2015 Controversies Conference and the KDIGO 2022 Controversies Conference decided to stratify patients into 3 risk categories: high risk, moderate risk, and low risk. The high risk group includes patients with known genetic complement abnormalities, patients who have had a prior transplant and a recurrence, as well as patients who, I'm struggling to see, high titer of factor H autoantibodies, which makes sense. Moderate risk would be loss of function, CFI variants, variants of unknown significance, or low titer factor H autoantibodies. And there's an interesting group of patients that will have a high titer of anti-factor H autoantibodies that don't have any evidence of TMA, and no one really knows what to do with them. But either way, if they have a low titer, they're still moderate risk. And low risk would be no genetic or acquired risk factors identified, a persistently negative factor H autoantibody, or a pathogenic membrane cofactor protein variant, because the thought being that that's associated to the membrane in the transplanted kidney, and so the risk is low even if the genetic predisposition exists. So now that we know these different risk categories, is prophylaxis indicated for any of these risk categories? This is a study from France using the French AHAS registry, which included primarily deceased donor kidney transplants, as you can see, with significant cold ischemic time, and these being risk factors for the development of thrombotic microangiopathy, in part due to ischemia-reperfusion syndrome, and then in part due to the drug effect itself. 75% were induced with thymoglobulin. 84% had CNI-based maintenance immunosuppression regimens, and 16% had mTOR inhibitor-based. What they found, as you can see here, in these patients who had a prior history of AHAS and proceeded with transplantation without any prophylaxis, is that the allograft survival was significantly different for those who had recurrence versus those who had no recurrence. The majority of patients with recurrence did have mutations in complement genes, primarily complement factor H. Other genes included complement factor I, MCP, C3, and complement factor B. Risk factors for recurrence were a low C3, historically when they first presented with AHAS. Interestingly, mTOR inhibition as maintenance immunosuppression was a risk factor, but not CNI as maintenance immunosuppression, which is surprising. Recipient age was a risk factor. Whether the patient experienced rejection or not was not associated with increased risk, which is also a surprise. And then abnormalities in complement factor H, complement factor B, and C3 were risk factors when they looked at the multivariate analysis. Whether or not they had a recurrent TMA post-transplant, allograft survival was still significantly impacted by the existence of a genetic mutation versus no mutation. And this is something that's come up in studies that have come after this, which is that even if a patient does not have histologic evidence of TMA, in certain instances, treating them with eculizumab or terminal complement blockade when the renal function is declining has led to a stabilization in renal function, and in some cases an improvement in renal function, which suggests that potentially there is low-grade or chronic TMA in the background that we are just not diagnosing, and would then explain why there was such a significant difference in allograft outcomes despite no recurrence, just based on the existence of genetic risk factors. This again goes back to the KDIGO controversies conference, but this is from 2015. And at that time, the high risk, moderate risk, and low risk categories were slightly different. But this is when they were very explicit about who they would recommend receive prophylactic therapy, and that's why I included this here. So for high risk patients and moderate risk patients, prophylactic therapy is advised with terminal complement blockade, and at that time that was eculizumab. For low risk, no prophylaxis is acceptable. Looking at post-eculizumab era data, this is a study using the UK evidence by Emily Glover et al., and it was published in Transplantation in 2023. 33 patients received prophylaxis and 33 did not. And you can see here that allograft survival was again significantly different. And this data was taken from 2002 to 2017, once again arguing for the use of prophylaxis. Now, what was special about this cohort is that there was a high prevalence of moderate and high risk complement genetic abnormalities, so they were a higher risk cohort to start with. But specifically, prophylactic eculizumab treatment improved renal allograft survival, and this was statistically significant in medium and high-risk recipients with 1-year allograft survival of 97% with prophylaxis versus 64% in untreated patients. So it's quite a remarkable difference. When they stratified it by KDIGO risk category, you can see that those who had moderate or high genetic risk did worse than those with low risk, once again reinforcing the recommendations from KDIGO for prophylactic treatment. What about the use of eculizumab rescue therapy? Would that make sense, following these patients closely and then intervening when they have a recurrence? So this is from the Dutch cohort, and the Dutch cohort is special in that they try to use low-risk induction protocol, low CNI dosing as maintenance therapy, and I'll go in detail about this more on a separate slide. But it's difficult to compare this cohort directly with the UK cohort, though they have in a future trial. So this group looked at just people who had relapses specifically. It was primarily living donor kidney transplants, 73%. Most of them received basiliximab induction. The trough CNI target was 5, but they did target an MPA, a mycophenolic acid AUC of 40 to 60, so they were slightly higher there. They introduced RAS inhibition and calcium channel blockers early, as well as statins. And they had strict blood pressure control with a target of less than 130/80 post-operatively. What they found was that there was about a 50% split in terms of those who recurred early versus those who recurred late, which is surprising because most prior studies will say that if aHUS recurrence happens, it will happen within the first year, at most 2 years. But here, 7 patients recurred at a median time of 3 months, and then up to 8 months. And then for the late aHUS recurrence, 8 patients recurred at 46 months. So almost 4 years later. The early recurrence group had evidence of systemic TMA that was not as commonly seen with the late recurrence group. And the late recurrence group had this slow decline in GFR associated with it, which I previously mentioned was noted in future studies as well. What they found was that rescue treatment is effective, but may result in irreversible loss of kidney function, which I think we all know, and there's a lot less residual renal reserve for patients who have one kidney versus patients with native kidneys who try for eculizumab discontinuation, then have recurrence, then get rescue therapy, which was sort of where the thought came from that potentially we could just treat at recurrence. 6 patients had eGFRs less than 30, and 3 patients lost their allografts entirely. And out of a cohort of 15, that is a significant number. But the overall recurrence rate, when they looked at, so this data just looked at patients who recurred, but then they looked at their registry, and they looked at overall recurrence within their program, and it was 23%. So it is lower than what has been seen in other programs, and that may have something to do with the induction regimen that they use and the fact that they use primarily living donor kidney transplants. So the next step was to directly compare the UK and the Dutch cohorts, and again, that's kind of difficult to do because they have very different induction regimens, and the UK cohort is primarily deceased donor kidney transplants. Moreover, the Dutch cohort had a low prevalence of high-risk genes. But when they compared directly, they found that there was no significant difference in death-censored graft survival using prophylaxis versus not using prophylaxis. And it was the UK cohort that used prophylaxis and the Dutch that didn't. That comparator study really is the only one that shows that there is no difference. Most other studies, there's not many, will show a significant difference when you use prophylaxis versus not. And this is a French cohort study that looked at recurrence-free survival, and you can see that there's a large difference. But they also looked at allograft outcomes, and they found that there was a significant difference for those that did not receive prophylaxis. So what about starting prophylaxis and then discontinuing at a certain set time point if they have no evidence of recurrence, if things are going well? The reason this question comes up is multifactorial. Cost is, of course, a big consideration because this is not cheap therapy, but also it's not a benign therapy. There is an increased risk of infection with encapsulated organisms as well as systemic fungal infections, and these were picked up in pharmacovigilance studies. There was a trial in native kidneys, Stop ECU, which demonstrated a 23% relapse rate after eculizumab withdrawal. And a more recent study, the Cure iHUS study, which was using the Dutch cohort, they withdrew, and this is in native kidneys, they withdrew eculizumab after a median of 13.6 weeks in 21 patients. 81% of those patients were at high or moderate genetic risk. They saw a 19% relapse rate at a median time of about 20 weeks. And when they reinitiated eculizumab, there were no chronic sequelae as a result. The challenge here is that they're not very specific about what their follow-up protocol was. The KDIGO controversies guidelines say you should be doing at least monthly blood work and then weekly dipsticks at home looking for proteinuria. They mention that they educate their patients to reach out to them if they develop hypertension or other systemic features of illness, or if they see that there's frothy urine or gross hematuria. But they don't mention how frequently they were following labs, and that may be because it was a multi-center study, so that may have affected that. But I would be curious to know how closely they were following these patients to have no chronic sequelae with treatment just based at time of relapse. And as we can see, that the percentage rate of TMA recurrence rate in patients with AHAS who tapered or discontinued eculizumab are typically around 20%. There's one study that's an outlier of about 44%, and most of these studies are looking at native kidneys specifically. The time to TMA recurrence will usually be within the first year, but as I mentioned, there is one study that shows that it could happen late without the systemic hemolysis markers that we typically see. And then renal outcomes after discontinuation will vary, but there typically are at least a few patients that experience allograft losses or CKD thereafter. And so in a transplant patient, it's difficult to take that risk. So looking at kidney transplant recipients in particular, looking at the rate of relapse in patients who stopped eculizumab was between 20% and 25%. There was, again, one outlier at 40%, and then there was a study in Brazil by Nato et al. In 2021 where patients stopped inadvertently, and the recurrence rate was 44%, and that was the same in native kidneys and transplanted kidneys. And so this corroborates that it's not just in native kidneys that we see these numbers, but we see similar numbers of relapse in kidney transplant recipients as well. So given all this data, the 2022 KDIGO conference on complement disorders, the recommendation was that for transplant patients, especially those at high risk or moderate risk, discontinuation of eculizumab should not be pursued, or terminal complement blockade more broadly. And if it is pursued, then extreme caution is warranted with monthly blood tests or weekly urinary dipsticks at home. So the key takeaway points here being that eculizumab prophylaxis in moderate or high-risk AHAS patients is an effective strategy to prevent recurrent disease and prolong allograft survival. There is evidence to suggest a bimodal distribution in risk of recurrence, both early and later, which means that if eculizumab or terminal complement blockade is discontinued, then we should be vigilant, not just early on, but chronically. Effective rescue therapy requires early detection of recurrence, which presents unique challenges, and discontinuation may be considered after a risk-benefit discussion occurs with patients with low-risk AHAS. So pragmatically speaking, there is no specific Canadian guideline that guides us in how we should manage these patients. And one of the things that comes up is, how should we screen these patients to begin with? And so we know there's benefit to genetic screening, but there seems to be variable practice in terms of what type of genetic screening takes place. And Alexion has sponsored a genetic test that screens for 14 gene variants, which include C3, C9, CD46, complement factor B, complement factor H, complement factor I, DGK epsilon, F12, INF2, MMAX, HC, plasminogen, thrombomodulin, VTN, and VWF. And this was done with the recommendation of a panel of experts. This is the most comprehensive screen, and I'll compare the Mayo panel that I was using as well as the Blueprints genetics panel, which we typically use. The nice thing about this testing, though, is that it's offered for patients with a clinical diagnosis of AHAS at no cost to the patient or the healthcare system. And the routine turnaround time is 4 to 6 weeks from when the sample reaches the lab and the report gets faxed to the physician. So how does the Mayo panel compare? As you can see, there are fewer genetic variants that are screened, and ADAMTS13 is included looking for TTP, so it's kind of all rolled into one. And same with the Blueprints genetics panel, ADAMTS13 is included. So the Alexion panel is inclusive of both of these panels and adds a few extra genetic abnormalities, typically within the coagulation pathway. I do think that there is work to be done in terms of coming up with what a protocol would look like that we can implement nationally, and then look at our outcomes in a registry, because right now the Canadian data that we have is obtained via the global AHAS registry. So it would be potentially beneficial to have our own registry if we have the volume of patients required. And one of the questions that can be asked not just is prophylaxis warranted, how do different induction therapies affect the outcomes, are there significant differences in living donor kidney transplant recipients versus deceased donor, not to mention what about living related kidney transplant, or kidney transplant recipients that receive a kidney from a related donor who may or may not have genetic abnormalities that we just don't know about yet, and so they have a negative screen but may be predisposed. But the other question too is there a difference between using eculizumab prophylaxis versus ravulizumab? And the nice thing in Alberta is that ravulizumab is actually automatically covered for the first 2 doses, and then most patients who have Blue Cross coverage will then have ravulizumab covered, and so there is incentive to use ravulizumab as the prophylactic agent of choice in that setting. But historically in Canada, at least, we've been using eculizumab. When I was at Mayo, we were using eculizumab as well. Not that there's a reason for that other than its historic availability. Looking at the different characteristics of ravulizumab and eculizumab, there's fewer free C5 excursions for patients who use ravulizumab versus eculizumab. And all that means is that there's just less breakthrough potentially. There's also reassuring safety data that ravulizumab does not carry a higher infectious risk than eculizumab. And when they looked at a pragmatic real-world study looking at the global AHAS registry, what they found was that safety outcomes were no different when patients transitioned from eculizumab to ravulizumab. This is just the details that there were 60 patients included, primarily female, and that's common for primary AHAS. 22% had genetic variants, which is actually quite low, 9 with an anti-CFH antibody, and 31 that had negative incomplete, and that's probably why the genetic variant number is low. And 19 of those patients had previous kidney transplants. And when they transitioned from eculizumab to ravulizumab, there was no significant difference in renal function, which is reassuring, or hemolytic markers. So in conclusion, there are many questions that need to be answered, but the limited amount of primarily retrospective data that we have does tell us that not prophylaxing these patients comes at a high risk. What the ideal prophylactic timeline is unclear. What the ideal monitoring post-discontinuation of terminal complement blockade after transplant would be remains unclear as well. Are there subset of patients that we should be looking at, not just from a genetic risk perspective, but from the risk with regards to whether or not they received a living donor kidney transplant or a deceased donor kidney transplant, what their induction protocol was, what their maintenance immunosuppression protocol is, do they have a history of rejection? These things are all still unanswered questions. We do know that genetic testing is needed for risk stratification. This is somewhere we can start, and using a more comprehensive panel makes sense as we try to learn more about this disease process. And so it's useful to know that this panel exists at no charge to us. The other important piece to highlight is that these patients will sometimes present atypically, and so for a patient that has a history of primary AHAS who undergoes transplantation and doesn't otherwise have evidence of systemic TMA or even biopsy evidence of TMA, to have a low suspicion that potentially this could just be a chronic TMA that's gone undetected if the GFR continues to decline over time in the absence of any other potential etiology. And those are my main takeaway points. I just wanted to acknowledge some of the mentors that I had at the Mayo Clinic, Dr. Altiers, who taught me most of what I know about complement and kidney disease, Dr. Nelson Learn, and Dr. Sandra Herman. Thank you.
Thank you very much, Dr. Barbir. Do we have any questions from the room?
I can hear you. I don't know if everyone...
Thank you. That was really interesting. My question is going to highlight the fact that I'm not a nephrologist and that I don't know about kidneys. So I was curious, and I'm asking from a living donor perspective. So you mentioned that people, if I understood you correctly, someone could have a complement abnormality or something, but you may not know, you may not have renal dysfunction at the time. So do you know of any programs that screen living donors to see if they have complement deficiencies? Is that only done in family history or just generic, like in general, or so it's not really relevant to your talk specifically, but it made me think about that when you were presenting.
No, it's a good question, and there's a lot of variation and recommendations around that as well. So I think most programs will screen living donors if the recipient has a history of primary AHAS, because it is a genetic disease for the most part, and so that will happen. Now, the interesting piece is there are some programs that will categorically not take living-related donors for patients with primary AHAS. The KDIGO controversies recommendations were not to exclude these living donors, but just to counsel them that even if they don't have a genetic abnormality, they may be at high risk. But they even used interesting language stating that even if they have a genetic abnormality, it's not necessarily a black and white, no, you cannot donate. You just have to be aware of the risk. Whether we screen other individuals that come forward and have normal kidney function, I mean, we ask them about their history, and if there's anything strange in their history, then we would screen them. But otherwise, it's not something that we do in routine screening because there's no indication to, unless of course they say, well, I have a family history of kidney disease, and then you kind of dig into that. But for the most part, there's no set protocol.
We have a question from the online group. We have a living-related transplant recipient, Yvonne. She's had her transplant for 36 years, and she's, talks about the toll that immunosuppressants have had on her over that period of time. But she wonders if the day will come when she no longer needs to be on the immunosuppressants and not the skin cancer, cyst, neuropathic pain, and other risks that can come with that.
I mean, I hope it does come. I don't think it's going to come within my lifetime. But I think there are different strategies that are being looked at, including, for example, regulatory T-cell infusions at the time of transplantation. But that's all very, very far away right now. So unfortunately, as things stand, maintenance immunosuppression remains necessary. Yeah.
Elena, thanks for the talk. Would you like to expand on the choice of immune suppression drugs in patients who are at risk for recurrent atypical HUS?
Yeah, I think what we're seeing from the Dutch data is, and again, it's a little bit difficult because they do everything all at once, and so it's difficult to tell which is most effective. Is it the fact that they will do primarily living donor transplants and then the maintenance immunosuppression is not as important? Because there's the initial endothelial injury with deceased donor kidney transplant recipients just due to ischemia reperfusion. That will happen at least to an extent. Or is it the fact that they use a low CNI target of 5 or avoid thymoglobulin, although I'm not convinced that thymoglobulin is specifically a risk factor for developing thrombotic microangiopathy. For instance, if you induce someone with thymoglobulin and then use a low CNI trough, would that be more beneficial than using basiliximab and using a higher CNI trough? We don't know the answer to that. But the other interesting piece in that retrospective study by Le Quintrec from the French registry was that mTOR inhibitor was a risk factor, but CNI-based immunosuppression was not. So really, at the end of the day, we don't know. There's not enough data to feel confident in saying this is optimal regimen that we should be following. The Dutch data, the other thing that they did was they controlled blood pressure tightly, and they're using early calcium channel blockade and RAS inhibition. I'm not sure how much that's contributing as well to their lower risk of recurrence. So I think that's a really good research question that we could look at if we could build a registry of these patients and do a multivariate analysis, or even look at the pre-existing data retrospectively. Yeah.
Just to follow up on that, was it a retrospective data that looked at where they showed the mTOR? So I mean, and did they know ahead of time that they had atypical HUS so that they might have actually put them, the high risk category, into that immunosuppressant protocol?
Mm-hmm.
That's where I wasn't sure with some of the data you're showing, how much of it was retrospective.
It's almost all retrospective.
Which makes it really difficult when you're looking back as to what the decision and what biases were there at the time of decisions about immunosuppressive therapy and management.
Yeah, and that's why so far the safest strategy is just to proceed with prophylactic treatment in moderate and high risk patients. And then the decision about whether or not to stop is where I think it gets a little bit more complicated. Some centers are moving towards stopping in the moderate to low risk categories, but I'm not aware of prospective data to that end yet.